Welcome, everybody. I'm Ann Rogers. For some strange reason, I happen to be your president this year. And I want to welcome you to this year's annual ASMBS meeting. And I am absolutely thrilled to be able to introduce this year's Mason lecturer, Dr. Rebecca Puhl. To give you some background, Dr. Edward E. Mason, considered the father of American bariatric surgery, created the first gastric bypass. I don't know if you knew that. He did this with the assistance of Dr. Chikashi Ito, and it was back in 1966 at the University of Iowa. And he began holding postgraduate courses on the surgical treatment of obesity at the University of Iowa in 1973. And these courses became formally incorporated as the American Society for Bariatric Surgery, or ASBS, in 1983. The first Edward E. Mason Founders Lecture was given on June 2nd, 1989, and the first lecturer was H. William Scott, Jr., MD, from Vanderbilt University Medical Center. And this year, as my presidency year's theme has been ending the stigma of obesity, I could think of no better person to give the Mason Lecture than the world-renowned Dr. Rebecca Puhl. Dr. Puhl received her undergraduate Bachelor of Arts with honors in psychology from Queen's University in Kingston, Ontario. She is, or was, originally a Canadian. She has dual citizenship. She then earned a master's degree in 2001, followed by a PhD in clinical psychology from Yale University in 2004. She is a tenured full professor of human development and family sciences at the University of Connecticut, and she's the deputy director of the Yukon Rudd Center for Food Policy and Health. She has uncountable peer-reviewed publications, and her research broadly addresses weight-based bullying, bias, and discrimination that's experienced by both children and adults. And I'm just unbelievably grateful that she was willing to join us today to speak on confronting weight stigma, understanding its harm, and embracing pathways for change. So please help me welcome Dr. Puhl. Thank you so much. I'm really thrilled to have you here.
Thank you so much. Good morning. I'd like to thank Dr. Rogers for her kind introduction and extend my gratitude to her and the ASMBS Scientific Committee and organizers for the invitation to give this keynote talk. And these are my main disclosures. And today I would like to start by acknowledging the pioneering work of Dr. Edward Mason, whose foundational contributions to the surgical treatment of obesity were significant and transformative. It's an honor to have this opportunity to speak to you as this year's Mason Lecturer. When reflecting on the creation of ASMBS 40 years ago and his leadership in the formation of the association, Dr. Mason's awareness of societal weight stigma and his intention to help reduce this stigma for patients with obesity were evident early on. In his reflections, he emphasized wanting to lessen patient unjustified self-blame for obesity. And his recognition of the importance of addressing weight stigma to improve the lives of patients with obesity were present from the beginning. And this is the topic that I'm here to discuss today because weight stigma remains prevalent in our society with harmful consequences for people with obesity. And so today I'll share some of our research in this area as well as work by others to summarize what we know about the prevalence and harmful health impact of weight stigma for people with obesity, what we know about weight stigma in the context of metabolic bariatric surgery and implications for patient care, and several pathways forward to effectively reduce weight stigma, both in clinical practice and in broader society, with attention to efforts in the medical community, in research, and in policy. And today, I'll be focusing on evidence in the context of two different and common forms of weight stigma that we've studied. The first is societal weight stigma, which is the widespread devaluation of people with obesity because of their body size or body weight. This stigma is fueled by widespread negative stereotypes in our society that people with obesity are lazy, lacking in willpower and self-discipline, unmotivated to improve their health, and personally to blame for their weight. And these attitudes lead to many forms of stigmatizing experiences for people with obesity, including bullying, discrimination, and unfair treatment. The second form of weight stigma is internalized weight bias. When people are exposed to weight stigma in their daily lives, these experiences can become internalized. And as people become aware of societal stereotypes and blame, they apply these views towards themselves, engaging in negative self-judgment, self-directed stigma, and self-blame. Now, I began doing research on weight stigma 25 years ago when I was a graduate student in the clinical psychology program at Yale working with Kelly Brownell. And when I started in this field, as you can see here, back in the year 2000, there was very little research on weight stigma. It was limited and it was scattered. Since then, research has significantly increased, particularly in the last 10 to 15 years. The good news is that we've learned a lot about the nature of weight stigma and discrimination. We know that it is prevalent in many societal settings. We know that it affects diverse populations and that it has a negative impact on people's health. And we know that Western societies like ours are largely responsible for perpetuating this stigma through cultural ideals of thinness and mass media messages that blame people for their weight. So we've learned a lot. The bad news is that we've also learned that this is a difficult societal stigma to change. It is challenging to shift strongly ingrained societal bias. And in contrast to other stigmatized groups in our society, reductions in weight stigma have been comparably lower. So this slide reflects data from more than 7 million implicit and explicit attitude tests completed by US participants drawn from the Project Implicit website. This is a website that hosts the Implicit Associations Test, or IAT, for public access, and it's a measure that assesses people's implicit biases towards different groups in our society. So in this study, long-term trends of public attitudes were examined across 14 years, from 2007 to 2020. And while we see substantial improvements and reductions in biases related to characteristics like race or skin tone or sexuality, implicit biases related to body weight decreased by only 1%. And this lack of change helps provide some context for why so many people with obesity continue to report experiencing societal stigma and discrimination. So among American adults who have obesity, the prevalence rates of weight discrimination, such as being treated unfairly in the workplace, range from about 19 to 40%. And in our national studies, we see fairly consistently that about 40% of adults have experienced some form of weight stigma in their lives. And weight stigma can be experienced by anyone. It affects women and men of all ages. It affects people across different racial and ethnic backgrounds and sexual and gender identities. We do see some variation across sociodemographic groups, and we typically see higher rates of weight discrimination among women and younger adults, and not surprisingly, stigma is most prevalent and harshest toward people at the highest weight categories. Now, in our multinational research, we've also observed a consistently high prevalence of weight stigma and discrimination, particularly among adults who are currently trying to lose weight. So a few years ago, we conducted a study of just under 14,000 adults engaged in a commercial behavioral weight management program across the 6 countries that you see here. And we found high percentages of adults across these countries reporting that they've been mistreated, teased, or discriminated against because of their weight. And there were very few and often no differences in people's reported experiences of stigma between these countries, despite somewhat different prevalence rates of obesity. Now, in this same multinational study, we also found that people reported many different interpersonal sources of weight stigma, ranging from family members to employers to people in their community. But a consistent finding is that people reported doctors to be one of the most common interpersonal sources of weight stigma in their lives, with approximately 2/3 of participants reporting that they had been stigmatized about their weight by a doctor. You can see here that percentages are somewhat lower for nurses, dietitians, and mental health professionals, but still present from these health professionals as well. And these findings align with a number of our US studies, some of which I've highlighted here, where we've examined different samples of adults with obesity and type 2 diabetes, and find again that weight stigma from medical professionals are commonly reported by as many as 2/3 of patients. If you look at the very bottom row of this table, this is a study with postoperative metabolic bariatric surgery patients, and we see that the percentages are just as high. And so collectively, these studies indicate that patients with obesity are aware of biased attitudes in their healthcare professionals and perceive stigma from them. Now, so far I've been referencing people's experiences of weight stigma, but when it comes to internalization of weight bias, we also see that this is prevalent among people with obesity. And my team has studied this in general population samples of US adults and samples of adults with obesity, and we find high levels of internalized weight bias in about 20% of the general population. This jumps to 35% among adults engaged in behavioral weight management, and it jumps again to over 50% among adults with higher levels of obesity. We typically find that men and women are similarly distributed at low levels of internalization, but once we get to high levels of internalization, 70% are women. We also see high levels of internalized weight bias in younger adults and white adults, those who are actively trying to lose weight, those who had a younger age of obesity onset, and a history of being stigmatized about their weight. And the graph on the right here highlights a similar pattern that we observed in our multinational data across 6 countries, consistently showing that the highest levels of internalized weight bias are present in people who have obesity, followed by less internalization at lower weight categories. And so these findings suggest that a considerable portion of people with obesity are at risk for internalizing weight bias, especially if they are engaged in weight management. Now, less is known about the prevalence of internalized weight bias in patients seeking metabolic bariatric surgery. So we don't really know what percentage of these patients have high levels of internalized weight bias, but we can predict that it would be at least 50% based on our prior studies of adults with higher levels of obesity. Of the limited work in this area so far, initial evidence shows fewer demographic differences in internalized weight bias among patients who are seeking or undergoing surgery compared to people with obesity who are not. So for example, women and men seeking surgery tend to endorse similar levels of internalized weight bias, as do adolescents and adults. Post-surgery, the evidence is a little more mixed, and so we need more research to determine what those potential differences are. So what does the prevalence of weight stigma and internalized weight bias mean for people's health? Well, substantial research evidence has demonstrated links between weight stigma and poor health behaviors and outcomes. And this includes psychological distress, unhealthy eating behaviors, reduced physical activity, but also increased physiological stress, metabolic risk factors, and weight gain. So I'm going to briefly summarize some evidence in several of these areas to give you a sense of what we know. First of all, evidence from prospective studies in recent years shows that experiencing weight stigma predicts weight gain and obesity over time, and these findings persist after accounting for baseline body weight and sociodemographic factors. What's interesting is that other forms of discrimination due to factors like age or race don't seem to have these same effects on weight gain. It's more unique to weight-based discrimination. Now, I've highlighted 2 examples of this work here. One is a study that I collaborated on with my colleague Diane Newmark-Steiner at the University of Minnesota on Project EAT, which is a longitudinal cohort of almost 2,000 adolescents who were followed through their mid-30s. What we found is that both girls and boys who were teased about their weight in adolescence at age 15 were more than twice as likely to develop obesity 15 years later in their mid-30s compared to their peers who were not teased in adolescence. And these analyses controlled for things like baseline body weight and sociodemographic characteristics, suggesting that weight stigma has implications for weight gain in adulthood, even when these experiences happen in early adolescence. In the example on the right, data came from adults over the age of 50 in the English longitudinal study of aging. And here, weight and waist circumference were objectively measured 5 years apart. And perceived discrimination about weight at time 1 predicted increases in weight and waist circumference and higher odds of developing obesity over that 5-year follow-up period. And again, these findings persisted after accounting for baseline body weight and sociodemographic characteristics. So a key question from this evidence is, why does weight stigma contribute to weight gain, and what are the mechanisms? Well, one reason is that people who experience weight stigma are more likely to engage in eating behaviors that promote weight gain, including binge eating, increased food consumption, unhealthy weight control practices, and emotional overeating, where people who experience weight stigma have a higher prevalence and a higher frequency of engaging in these unhealthy eating patterns. And these have been demonstrated in both clinical and community samples of adults with obesity. Now, one of the reasons why these maladaptive eating behaviors are observed is that individuals may be coping with the emotional distress of weight stigma by turning to food. Now, I began studying how people cope with weight stigma way back in 2006, and our first study examined 2,400 women who were enrolled in a behavioral weight loss support program. Now, women reported using many different coping strategies to deal with weight stigma, but 79% reported that they tend to turn to food as a coping strategy, that eating was temporarily relieving their distress of being stigmatized. This certainly aligns with what we know from research in psychology, which is that eating is a very common coping strategy in response to stress. We also know that stigma is a legitimate and chronic stressor for many people with obesity, so it's not surprising to see increased food consumption as such a commonly reported strategy. And we've continued to document similar findings in our other studies since then. A more recent example here on the right is from a national community sample of US adults, where we found that the more weight stigma reported, the more that people increased their eating and food intake. Now, additionally, the chronic stress of weight stigma may also contribute to lower physical activity and exercise, oftentimes because physical activity settings are places where people with obesity feel vulnerable to being stigmatized about their weight. And so they escape anticipated stigma by avoiding these settings. Now, weight stigma, we know, induces negative feelings about engaging in physical activity, as well as lower intentions to be physically active, as well as avoidance of exercise. And our multinational data, again, show consistency in this pattern, where adults who had experienced weight stigma avoided going to the gym for exercise and had lower self-efficacy for engaging in exercise. And again, these links were documented over and above weight status and sociodemographic characteristics. The chronic stress of weight stigma may also contribute to weight gain through dysregulated physiological reactivity. So compared to people who do not experience weight discrimination, those who do have elevated physiological stress responses. And this includes increasing levels of C-reactive protein, higher cortisol and blood pressure, higher A1C levels, and increased risk of high allostatic load. And importantly, these findings persist independent of adiposity, which suggests that it's the experience of weight stigma, not just weight status alone, that is increasing vulnerability to these physiological responses. So when people react to an experience of weight stigma with emotional distress, this can in turn have a negative effect on their physiological stress responses. And this highlights the stress-induced health consequences of stigma, which can trigger an obesogenic process through these physiological and biochemical pathways. Now, I want to highlight that even if people don't experience weight stigma directly in an interpersonal interaction, just being exposed to weight stigma that we see in the media can have negative implications for physiological stress. I'd like to highlight 2 experimental studies here led by prior graduate students that I've worked with. In one study depicted on the left, this was led by Natasha Shvei, women of different body sizes were brought into the lab in individual sessions where they were randomly assigned to one of 2 experimental conditions. In one condition, they watched a 10-minute video depicting clips of neutral advertisements that were unrelated to weight. In the other condition, they watched a 10-minute video consisting of clips from popular television shows and movies in which female characters were stigmatized or made fun of for their weight. Participants' salivary cortisol were assessed both before and after watching either of these videos. Baseline cortisol levels did not differ between these groups, nor did demographic characteristics. What was found is that women who watched that stigmatizing video had significantly greater cortisol reactivity after the video compared to those who watched the neutral video, irrespective of weight status, showing that women find these stigmatizing clips to be stressful to watch. And these findings persisted after accounting for a wide range of variables like minutes since waking, days since last menstrual cycle, age, body weight, stress, depression, etc. The study depicted on the right was led by Greg Panza. This was a randomized trial of women with obesity who had either high blood pressure or normal blood pressure, and he assessed the influence of watching those same two videos on cardiovascular reactivity. And it was found that laboratory systolic and diastolic blood pressure increased more in women with high blood pressure than normal blood pressure only after watching that Stigma video, not the neutral video. And ambulatory blood pressure and heart rate also increased more among women with high blood pressure during sleeping periods after watching that stigmatizing video. So these findings provide evidence that just being exposed to weight stigma in the media that we watch can increase cardiovascular reactivity and high blood pressure, both in the laboratory and under ambulatory conditions. Now, this experimental evidence can help explain recent studies documenting links between weight stigma and cardiometabolic risk factors. So recent evidence is showing that experiencing weight stigma is associated with higher odds of meeting criteria for metabolic syndrome, heightened risk for cardiovascular disease, and myocardial infarction. And additionally, internalized weight bias in particular is positively associated with visceral adiposity, after accounting for factors like age and race. And this suggests that we can consider weight stigma as a chronic stressor and a potential modifiable risk factor for poor cardiometabolic health. So in light of these findings, it's not surprising that we're seeing in our studies that weight stigma has concerning implications for weight management. As one example, we conducted a large US study of over 18,000 adults engaged in a commercial behavioral weight management program where we found that those who had higher levels of internalized weight bias had lower odds of achieving 5 to 15% weight loss, higher odds of 5 to 10% weight gain, and poorer weight management behaviors. And these findings persisted after we controlled for participants' weight status and sociodemographic characteristics, suggesting that internalized weight bias is potentially creating barriers for weight management. We see a similar pattern in our multinational data. Again, these are adults engaged in behavioral weight management. And across all 6 countries that we studied, those with internalized weight bias had a greater % weight gain in the past year. And it's possible that this was contributing to weight gain through links that we observed between internalized weight bias and exercise avoidance, higher perceived stress, and more frequent eating to cope with stress. Our research is also showing that internalized weight bias is impairing efforts to maintain weight loss, independent of how much stigma is experienced. So this time, we studied a national community sample of US adults who had lost at least 10% of their weight in the past year. Some of these adults had maintained that weight loss while others regained it. We found that typical behaviors that are linked with sustained weight loss, like dietary monitoring and self-weighing, were actually not significant for these groups. But there was unique predictive value of weight stigma, and in particular, internalized weight bias, when it came to who maintained versus who regained the weight. And specifically, as levels of internalized weight bias increased, the odds of maintaining weight loss decreased by almost 30%. So, internalization and self-blame resulting from weight stigma may be interfering with people's efforts to maintain weight loss regardless of how much stigma they've experienced. So an important question in light of this evidence is whether helping people to reduce their internalization of weight bias can improve weight loss outcomes. There's been very little empirical attention to this question, but emerging studies are suggesting potentially yes. So as an example, in one study, patients with obesity who were in a behavioral weight loss treatment program found that reductions in internalized weight bias were associated with greater weight loss over time. Another study of weight loss maintainers in the National Weight Control Registry also found that weight loss at 1-year follow-up was associated with reductions in weight bias. Now, the data is lacking in patients seeking metabolic bariatric surgery, but we do see that among those patients who have high levels of internalized weight bias, about 40% report that if they could have opportunities to talk about weight stigma with their healthcare provider, that this would help them lose weight. What we are starting to see is that internalized weight bias may contribute to clinical attrition in medical treatment for obesity. So the study I'm highlighting here was one in collaboration with my colleagues at Hartford Healthcare in Connecticut, who really conducted the first examination of these links in patients engaged in medical weight loss treatment, a quarter of whom also had prior metabolic bariatric surgery. And in this study, 1/3 of patients dropped out of the medical weight loss program during the 6-month study period. And those that dropped out had significantly higher levels of internalized weight bias compared to those who remained in treatment. And there were no other differences between these groups, whether that was demographics, weight status, history of surgery, experienced stigma, or medications prescribed. Now, when we hone in specifically on the emerging studies that are starting to examine links between weight stigma and health in patients seeking metabolic bariatric surgery, we essentially see the same patterns that I've just summarized in community samples of people with obesity and those engaged in behavioral weight management. So in preoperative patients, initial evidence is showing that both experienced weight stigma and internalized weight bias are contributing to psychological distress, notably depression and anxiety, as well as binge eating, emotional eating, and eating in the absence of hunger. The few studies that have examined physical activity are also showing links with weight stigma and reduced physical activity, as well as exercise avoidance. And most studies so far in this area are controlling for demographic and weight-related covariates, which is highlighting the unique role of weight stigma in the health behaviors of pre-surgical patients. Now, there's been even less research on weight stigma in postoperative patients, highlighting another area warranting increased attention. But of this emerging evidence to date, we see again that both experienced weight stigma and internalized weight bias are contributing to psychological distress, worse eating and dietary adherence following surgery, and exercise avoidance. In prospective studies looking at weight loss outcomes, experienced weight stigma hasn't really been studied yet in this context, although there was a new study just published last week out of the University of Utah, which shows that experienced weight stigma does improve from pre to post-surgery, and that this improvement is associated with decreases in dysregulated eating and reductions of weight. But more research is needed. The initial evidence looking at internalized weight bias is mixed. So some research is showing that higher levels of internalized weight bias prior to surgery is predicting less weight loss post-surgery, although one study did not find any effects on weight outcomes. So again, more research is needed here. And I will say that most of the studies in this emerging literature are accounting for factors like baseline weight status, type of surgery, depression scores, time since surgery, and demographics. What I do think we can take away from this initial evidence here is the importance of addressing weight stigma in all phases of a patient's journey in bariatric care to optimize their health and treatment outcomes. Whether that's preoperative counseling, postoperative psychological support, multidisciplinary care, these all provide opportunities to help reduce the psychological and health-related consequences of weight stigma. So taking a step back then, the collective evidence of weight stigma and its health consequences demonstrates the ways in which weight stigma contributes to weight gain and reinforces obesity. The psychological distress of experiencing weight stigma can lead to maladaptive coping strategies as well as internalization of stigma, and these can increase and reinforce unhealthy eating behaviors and risk factors like dysregulated physiological reactivity, which contribute to weight gain. And this ultimately creates a harmful cycle because increased weight gain makes a person more vulnerable to experiencing weight stigma, and that just sets the pathway in motion again. And in this sense, it's helpful to think about weight stigma as both a psychosocial contributor to obesity and a psychosocial consequence of obesity. Now, one health impact that I haven't spent as much time talking about is the impact of weight stigma on patient care. Several decades of research have documented the presence of weight bias and stereotypes among medical professionals towards patients with obesity. And stigmatizing attitudes among healthcare providers include the same weight-based stereotypes that we see in the general population. And these have been reported by a range of healthcare professionals across different specialty areas and disciplines. We also see that physicians express weight bias at similar levels to the general population, and that weight bias is also present among health professionals who specialize in obesity. So this evidence reiterates that the medical community is not immune to societal weight stigma, and that even if unintentionally, they may be communicating this in patient care. Now, as I mentioned before, patients are aware of these biases, and we also see from research that these biases are negatively impacting their health care. As an example, a review of 21 studies examined healthcare experiences among patients with obesity, and patients reported disrespectful treatment from healthcare professionals, anticipation that they would be treated unfairly because of their weight. They had low trust in clinicians and ambivalence about using health services, and reported stigma-related barriers, such as inadequately sized medical equipment for their body size. And these experiences led people to switch doctors or to avoid or delay healthcare altogether. We are also seeing some evidence suggesting that with each increase in a patient's BMI category, that there's an approximately twofold increased likelihood of perceiving stigma in primary care. And again, we've seen these issues emerge in our multinational data as well, where internalized weight bias seems to play a particularly salient and consistent role in people's healthcare experiences across different countries. So again, we found that compared to people who had low levels of internalized weight bias, those with higher levels of internalization were more likely to avoid healthcare. They were less likely to obtain frequent routine checkups, perceive that their doctors were negatively judging them about their weight, and felt that their doctors had less respect for them and didn't listen to their needs. This pattern was consistent across each of the 6 countries that we looked at, and weight status was not associated with any of these healthcare experiences. So, the increasing awareness of weight stigma in healthcare, along with the documented health consequences of weight stigma, have led to an increasing recognition of weight stigma as a public health issue. And this includes position statements from national obesity organizations and ASMBS calling attention to the harms of weight stigma and the importance of addressing this problem both in and outside of the medical community to improve patient care for people with obesity. However, in the context of metabolic bariatric surgery, eliminating weight stigma requires the challenge of tackling not just the stigma of obesity, but the stigma of surgery itself. So people with obesity are stigmatized both for their weight and for the treatment approach that they engage in to lose weight. And if that approach is surgical treatment, the stigma is compounded. Public perceptions of metabolic bariatric surgery remain inaccurate and misguided and are contributing to societal stigma. As an example, a 2018 national US study found that more than 1/3 of respondents believed that individuals who had metabolic bariatric surgery chose the easy way out, and just under half believed that they underwent this surgery for cosmetic reasons. Outside of the US, research in places like the UK, France, and the Netherlands show that people who view obesity as an issue of personal responsibility are more likely to have negative attitudes towards people who are undergoing metabolic bariatric surgery. These public attitudes are common, and they can be influential, and they can keep some people from seeking surgical treatment. As an example, a review of 19 studies examining patients' experiences of stigma related to metabolic bariatric surgery found that patients report being stereotyped as lazy, that they face disapproval and judgment for choosing to undergo surgery, and they internalize this shame from others and feel conflicted in their decisions to pursue surgery. They also report that these stigmatizing experiences lead them to delay or opt out of surgery despite being eligible, that they go to great lengths to conceal their surgery from others, feel less trustful of healthcare professionals, are more likely to switch doctors, drop out of post-surgery programs, and experience less social support and more social isolation. So on the one hand, we might view surgery as a way for people to escape weight stigma through weight loss, but for many people who seek metabolic bariatric surgery, the stigma of surgery is instead a barrier, and even a reason that eligible individuals reject surgery as an option. To highlight this further, I'm collaborating with my colleagues at Hartford Healthcare in Connecticut to study residual weight stigma that can linger for patients following metabolic bariatric surgery. This research is currently ongoing, but a snapshot of data collected so far from just over 200 patients who underwent surgery found that 33% reported being judged by others for taking the easy way out. 36% were more self-critical of their weight after losing weight because of how people were treating them. And we also found that 27% concealed their surgery status from others. We're also seeing in this data that patients with higher levels of internalized weight bias prior to surgery experience significantly less total percent weight loss following surgery, regardless of demographics, weight status at surgery, and days since surgery, none of which were significant. And experimental studies in psychology show that this idea of residual stigma is a real effect when it comes to public attitudes towards people who have lost weight through metabolic bariatric surgery. These studies typically randomly assign participants to read one of several vignettes, each with an identical photo of a person who was described as formerly having obesity, who experienced significant weight loss either through surgery or through diet and exercise alone. And study participants are then asked to rate their impressions of the individual portrayed in the vignette on a variety of traits and characteristics. Consistently, what these studies show is that participants rate the individual who was depicted as losing weight through surgery as being more lazy, sloppy, less competent, less sociable, less attractive, and having less healthy eating habits. Whereas the individual who was portrayed as losing weight through diet and exercise is rated more positively, viewed to be more competent, more self-disciplined, more responsible for their weight loss. Moreover, what we see in this research is that the individual in the vignette who was depicted as losing weight through surgery received lower employability ratings from study participants, meaning that study participants would be less willing to hire a person for a job if they lost weight through surgery than through diet and exercise alone. So collectively, these examples highlight that there are multiple ways that weight stigma can affect patient utilization and experiences of metabolic bariatric surgery, because there are, in effect, multiple weight stigmas that patients are facing simultaneously. They experience the societal stigma of obesity, they face stigma for undergoing surgical treatment, and they engage in self-stigma or internalized weight bias. And it's the combination of these that creates significant barriers that can lead to delay or rejection of surgery or interfere with positive outcomes following surgery. So in light of persistent weight stigma, what are the remedies? What actionable steps can be taken to reduce weight stigma? I'd like to highlight 3 pathways for change that are required for effective stigma reduction. And this involves taking steps to remove weight bias from the clinical care setting, increasing research on weight bias and in the context of metabolic bariatric surgery, and engaging in increased advocacy for policies to eliminate weight stigma and discrimination. So starting with the clinical care setting, it's important to be aware of personal assumptions that we make about weight and obesity and how those implicit assumptions affect communication with patients. We all have blind spots, and when we are busy, when we are distracted, we are more likely to make biased decisions. So practicing conscious awareness and self-assessment of our attitudes can reduce the impact of implicit bias in our communication and can promote more compassionate patient care. And this can be achieved through reflection of how our views about weight affect the way we communicate, challenging stereotypical thoughts when they occur, acknowledging patients' prior lived experiences with obesity and stigma, and soliciting feedback from others about potential blind spots that we might not be aware of. It's also important to closely examine our attitudes and knowledge about the etiology of obesity, because causal beliefs about obesity are strongly linked to expressions of weight bias. Again, evidence from experimental studies in psychology show that when people attribute the causes of obesity to individual characteristics, such as self-discipline or motivation or willpower, that these attributions increase and worsen stigma. In contrast, when people recognize the multiple complex contributors to obesity that include factors outside of personal control, this reduces weight stigma. So it's essential to acknowledge the complex etiology of obesity, not just with ourselves and our colleagues, but also with our patients. Because when patients become aware of the complex factors involved in body weight regulation, not only does this help to reduce their self-blame, but it also increases their self-efficacy for making health behavior changes. Now, one of the most important factors in reducing stigma and optimizing supportive patient care is how medical professionals communicate with patients about body weight and obesity. Most stigmatizing experiences that patients report in healthcare occur in the context of communication with a healthcare professional. Language affects how we think about people and how we treat them, and engaging in respectful and non-judgmental communication is fundamental. And that means using patient-centered language, engaging in active and reflective listening, acknowledging patients' lived experiences. And when healthcare professionals engage in stigmatizing conversations with patients, patients do not have an increased desire to lose weight. Instead, they engage in more internalization and self-blame, have lower trust in their clinician, and are more likely to avoid care. So when it comes to language and terminology, certain words or phrases to describe body weight can lead patients to feel stigmatized, and this can jeopardize important discussions about health. So one way to enact person-centered communication is to simply use people-first language, which avoids labeling people by their medical condition and instead identifies the patient as a person first. People-first language for obesity has become an accepted standard endorsed by national medical organizations, including ASMBS, and is really encouraged for communication with patients and clinicians and other medical personnel. And interestingly, initial evidence with patients seeking metabolic bariatric surgery also shows that they prefer people-first language to be used in their healthcare interactions. Now, I will say at the same time that individual preferences for terminology can differ according to demographic characteristics. And my team has now conducted about half a dozen studies on language preferences for obesity, and we see considerable variation across factors like gender and sex and race, and also people's experiences with body weight. So it's helpful to recognize that the words that patients feel most comfortable using to describe their weight aren't always going to be the same. And as medical professionals, we want to be using terminology that patients are most comfortable with. Now, engaging in respectful communication also means paying attention to the visual aspects of your communication that can reinforce weight stigma. Many public-facing images portray people with obesity in a stereotypical and negative manner, and these even emerge in the obesity field, whether it's images and research presentations at conferences or educational materials for patients in the clinic setting. But a number of organizations that I've listed here have created free image banks, which contain respectful images of people with obesity that can be used for educational and public use. And these can help reduce stigma and increase accurate coverage of obesity-related topics. So I encourage you to take advantage of these options for your visual communication needs, whether that's research, education, or patient outreach. Promoting respectful communication is going to be most effective if it includes training and education for all medical staff. So we do recommend providing in-service education on weight stigma for all personnel, including health professionals, medical assistants, nurses, front desk employees, and back office workers. And of course, stigma reduction efforts need to extend to the physical clinic setting to provide a safe and welcoming environment. That means not only having sufficient medical equipment and facilities that can accurately assess patients with obesity, but also procedures for respectfully weighing patients to help eliminate unnecessary barriers that may otherwise deter patients from seeking care. Now, the stigma reduction strategies that I've just briefly summarized here align with the ASMBS position statement on weight bias and stigma that was published in 2019, which highlights recommendations from ASMBS to increase sensitivity training for healthcare professionals about weight bias and non-stigmatizing communication, and to ensure appropriate resources and accommodations to appropriately treat patients with obesity. So there is a clear blueprint for strategies to reduce stigma in the field of metabolic bariatric surgery. Now, more detailed information on strategies to reduce weight stigma in patient care is also available on a new website that we've developed called supportiveobesitycare.org. And this website contains free, evidence-based, downloadable handouts, videos, and podcasts that are really intended to equip medical professionals with tools to provide more respectful and compassionate patient care. And these are suitable for educating health professionals, staff, and trainees across diverse units and disciplines. So we encourage you to use and share these resources as well. Okay, beyond patient care, beyond the healthcare setting, a key pathway necessary for effective stigma reduction is increasing research in this space. There is currently insufficient research on weight stigma and metabolic bariatric surgery. The current evidence is scattered and it's mostly cross-sectional. Most study samples are comprised of white middle-aged women. We see very little research with more diverse populations or younger populations, and there's been very little empirical attention to the role of weight stigma in post-surgery outcomes. So we need to be prioritizing prospective studies to identify the predictive nature of weight stigma on treatment outcomes, to assess how stigma impacts health-related outcomes following surgery, and whether interventions targeting stigma can improve patient outcomes following surgery. Now, to maximize the impact of these efforts, multidisciplinary research teams are needed because most researchers who study weight stigma are not in the obesity field. They are in social sciences and public health and psychology. So prioritizing cross-disciplinary science is going to be important to help advance this field forward. Now, addressing these priorities requires a concerted effort to actively encourage more research in this field. This table summarizes the total number of accepted conference abstracts from the last 5 ASMBS national conferences and how many abstracts of that total number involved research on weight stigma. Now, no data were available for 2020, 2021 because those were pandemic years and abstract submissions were halted. And I'd like to thank Cindy Chambers at ASMBS for her assistance in compiling these numbers. You may or may not be surprised by these numbers, but let's focus on the good news. The good news is that this year's abstract submissions on weight stigma have increased to 8% of conference abstracts. And it's encouraging to see this work being presented here this week. My hope is that these percentages will continue to increase going forward to keep this year's momentum going, because it will be just as important for research on weight stigma next year and the year after that and the year after that as it is today. The final pathway for change that I'd like to mention is the need for policy remedies to eliminate weight discrimination. Scientific and medical communities have called for policy implementation in this area because there is a barren legal landscape in the US and in the rest of the world when it comes to weight discrimination. So in the US, almost everywhere, it is legal to discriminate against people because of their body size. The state of Michigan is one exception. They have passed a statewide anti-discrimination law back in their Civil Rights Act of 1977. And that added body weight as a protected characteristic alongside other protected categories like age and race. At the local level, we've seen a handful of cities scattered across the US that have passed similar laws to ban weight discrimination, most of which are on this map. You likely heard in the national news in 2023 that New York City passed a law that added body size as a protected class, so it is now illegal to discriminate against people based on their body size in New York City in areas of employment, housing, and public accommodations. Now, when we look at what's happened in Michigan since their law was passed almost 40 years ago, we see favorable outcomes. First of all, we see from research that there are lower rates of weight-based employment discrimination in Michigan, particularly among women, compared to other states without this law. And second, there's been no unmanageable influx of discrimination complaints, which was an initial concern when this law was passed. But in fact, very few lawsuits have been filed, which suggests that this law appears to be helpful as a measure to prevent discrimination. And in the past couple of years, other states have introduced similar statewide laws, including Massachusetts, New Jersey, Vermont, New York, all proposing to ban weight discrimination. So we are seeing increasing movement on weight stigma as a policy issue. And there's considerable public support for these policy measures. For over a decade, my research team has been tracking public support for potential laws to prohibit weight discrimination in the US, and across 9 of our national studies, we found that an average of 2/3 of Americans support adding body weight as a protected class to their state civil rights law, and almost 3/4 are in favor of passing a new law that would ban weight discrimination in the workplace. Now, we know that policy can be a meaningful and effective remedy for addressing discrimination. We also know that medical professionals have an important role to play in supporting these policy efforts, whether it is sharing knowledge about weight stigma in your professional circles, advocating for education on weight bias and medical training, or contacting state legislators to express support for policies to ban weight discrimination. And this policy pathway is particularly important if we want to move the needle to reduce weight discrimination in a meaningful way. If we look back at the last 2 decades of research on weight stigma, we know that smaller scale, individual level interventions that try to reduce weight stigma don't work very well. They typically show minimal improvement and little sustainability over time. Broader remedies are necessary to effectively eliminate weight stigma, and it's only by prioritizing broader efforts in the medical community, in public health communication and mass media messages, and through implementation of policies that there can be meaningful change in our society where people of all body sizes are treated equally and with respect. It's time for us to lead with compassion and evidence to prove that dignity does not have a body size. As I wrap up here, I would like to acknowledge my research collaborators for their support and collaboration on the research that I've shared today, And thank you again for the opportunity to speak to you. I invite you to connect with us at the Rudd Center on social media if you'd like to learn more about the work that we're doing. Thank you very much.
It's my honor to present you with this wonderful plaque. Be it known, the Society hereby recognizes and honors Rebecca Puhl, PhD, for her Edward E. Mason Founders Lecture.
Thank you so much.
Thank you.